Thank you for coming. Gracias por venir, por donarnos su tiempo, for giving your time. Gracias al maravilloso equipo de eventos de la Cardio. And thanks to our friends in Philips for helping us with this space. Pues tengo el honor y la felicidad de presentarles a mi mentor, ¿sí? El doctor Matthias Friedrich. Él es el jefe de Imágenes Cardiovasculares de McGill y un gran investigador. So I have the pleasure to introduce you my mentor and friend, Dr. Matthias Friedrich, the Chief of Cardiovascular Imaging and the Scientific Director of the Courtois Program. Yo no les puedo decir cuánto aprendí con él y cuánto me sigue enseñando y apoyando. Tener un mentor es importante. So, what I was saying is that...
I understand.
Okay. So, y bueno, ojalá puedan disfrutar esto de una de las personas que ha cambiado la cardiología moderna y la va a seguir cambiando con lo que viene. Muchas gracias. Os dejo con...
So after the advertisement break, welcome and thank you very much to Carlos and the team at the La Cardio for inviting me. It's an honor and a pleasure for me to be here. And I can only, the nice introduction, it's a pleasure for me to help mentoring Carlos, although I don't think he needs that. He's a fantastic cardiologist. And I've also learned a lot from him, especially in the area of congenital disease. So I will talk about the clinical impact of cardiac magnetic resonance imaging and after having done that, especially focus on some new developments which relates to the research I am involved in. And it will be a fast pace, so buckle up, and I hope you had coffee because I will have to take you on basically a tour de force. But before doing that, I want to disclose that I'm also involved in software development because there's only so much you can do in academia. Eventually, to translate science into actual application, you need to have the help of industry. And sometimes these big vendors, they have their own agenda, and sometimes it's difficult for them to understand and decide which technology to use, and that's why I always found it easier to found companies for doing that myself, with the support of my wife, who's also a doctor, who's here, and with others. So this is, when I talk about software, just be aware, especially Area 19 Medical is the company that is also involved in the research here. So in cardiology, we have basically 4 imaging modalities. None of them is perfect at everything. Echo is the best for bedside, quick assessment of LV function, pericardial effusion. CT is the best in morphology, high resolution, but unfortunately it's only good at morphology and not much in other stuff. I think nuclear cardiology is not important at all. I think it should have been gone a long time ago. And then there's MR, which is a pretty good global player, can do pretty much everything and more. But CMR has, as it's called, has its own challenges. But let's first do a little bit, and it's just one slide, I promise, on the physics, but it's important. MR works with protons. We all have trillions of protons in our body, actually more than there are stars in the universe. So these protons behave in a certain way in a magnetic field. And the fundamental difference to CT, ultrasound, and others is that while I'm also putting in a high energy pulse, it is not about the density of the tissue like in CT, where I just brutally fire through and look what comes out at the end. Or an echo, which is very gentle. I beam something not very high energetic and wait for the echo to come back. MR works differently. It kind of excites proton. They go into a higher stage, higher level energy field, and then they bounce back. And with bouncing back, they emit a small amount of energy that we can measure and then turn into images. So this is the basic principle. So the important fact to know is that the behavior of these protons depends on the molecular environment. And that's the key difference, for example, to a CT. So the signal intensity I'm getting from MR is a direct reflection of the molecular environment of that proton. So a proton bound in water behaves very differently from a proton bound in fat. So if I understand that, if I use the software in the scanner and then the pulses properly, I can have a water-specific image, a fat-specific image, or anything in between. So that's important to understand, because this gives us some opportunities we otherwise would not have. So MR is by far the most versatile technology, and this is not something that you can argue with. You can do LV function, as you can see in the left upper. You can inject a contrast agent, look at perfusion. You can do an angiogram. You can measure flow actually more accurately than any other technology. And I will talk today also about oxygenation-sensitive MR, which is a way to track changes of oxygenation, to be precise, hemoglobin oxygenation in the heart. So MR, to just run through a list, is safe because it doesn't induce cancer. In fact, the energy level is, the energy that we beam in an MR is about 64 megahertz at 1.5 Tesla or 128 megahertz. So that's about what we have here everywhere in the room, because you probably have your favorite radio station at whatever, 99.5. That's megahertz. That's the frequency of the radio waves. And it's the same range of frequency that we use in MR. CT works in terahertz, very high energy, and can therefore can actually kick out electrons from atom shells. And therefore it can, theoretically, and it leads to DNA breaks. DNA breaks, we have that, as we're sitting here during my lecture, each of you will have about 1,000 DNA breaks. And that's okay, because we have a very good system to repair that. But if you do not have 1,000, but you have 20,000, the likelihood that some of these repairs don't work well is higher. And then these repairs sometimes lead to just dysfunctional cells, they die, but they may lead to a cell that is immortal, and that's also called a cancer cell. That's not happening with MR. In fact, we have not only that, but you also have a high spatial resolution, all these not as high as CT. I want to be very clear here. You have a consistent image quality with a fairly high accuracy and high reproducibility for clinical trials. That's important. We have a smaller observer dependence. The images are typically explaining themselves fairly well. We have an excellent tissue contrast, which is very important. We can generate images where you can beautifully identify the myocardium and differentiate it from blood, etc. And then also, very important, you can do that all in one scan. That doesn't mean you have to do it all in one scan, but you can do a lot. So if you have a congenital patient, you want to do flow tissue characterization during the same scan. And still it takes quite some time, and that leads me to the limitations. MR has big problems because it's a complex technology. These scanners are really, this is basically a technical miracle to build them. We have long scan times. You need to have expert technologists, as you have here at La Cardio, where you have 4 of those. You can consider yourself blessed that you have that. So expert technologists to run these scans, and then you have to have expert readers who understand what they're looking at, and you have to use special software. And at the end we also typically these days often need contrast agents. So this makes this technology expensive, complicated, and that's why many are saying, oh, wow. And for some radiology departments, it's difficult to even implement that, because then they can do 4 or 5 knee scans during the same time, and it's much easier to do that. But there's definitely a clinical value to cardiovascular MR nevertheless. So the morphology can be used to rule out or to assess for hypertrophy, any morphological abnormalities, things like papillary muscle abnormalities, etc., but also regional wall thinning that you see in sarcoid disease or after infarcts. You can look at function, not only ejection fraction, which is my point, I think a little bit overrated, but also stroke volumes, stroke volume index, but also look at regional function with strain. You can extract that from the same images. Then maybe the single most important differentiator from any other imaging modality is tissue characterization. So with various techniques, and I will not go into too much detail, we can visualize global fibrosis, scar, edema, infiltration, and other problems like iron deposition or hemorrhage. And I'll come back to the hemorrhage later because it's, I think, clinically a very important and underrated problem. And then you have flow quantification, which also uses, in echo we use the Doppler effect. In MR we can measure the speed with which the protons cross the slice, so it's a pretty accurate method. It has a few limitations, but in general is more and more clear that if you're not very sure with the echo, the MR gives you definitely an excellent answer. And there are lots of papers saying that if you use that pre-op, it actually improves prognosis of patients. And then for congenital angiographies are, of course, also very helpful to identify vascular anatomy, but also look at pulmonary embolism, which may surprise you because typically CT is used for that. But I can tell you, I did it myself often, it also works very well with MR and without the radiation. So you probably all have seen MR images, so I can make this fast. So here you can see on the left side, you can see 6 long axis views. These days, typically it takes 2 breath holds. It would have taken almost 45 minutes when I started doing cardiac MR in the last millennium. And on the right side, you see a color-coded visualization of the left ventricle. But the colors here mean something. The colors actually are a pixel-wise presentation of strain. And if you look at that, and I tell you that red is normal, yellow is borderline, and blue is an abnormal, is basically dyskinesis, you do not need to be an expert. And having seen thousands of images, you can just look at the color and see, oh, wow, there's dyskinesia of the apical wall, in this case with stress-induced cardiomyopathy. So strain can also be used or a similar technology can be used to track features of the left ventricle. And here in Latin America, we have Chagas disease. And Daniela Valderrama Shuri here did work that was presented at the last ACC. And she could show that in patients with Chagas disease, you can actually see in the relationship between the base and the apex, even in patients with normal ejection fraction, you can see that there's a gradient of the function on that high resolution level. So then tissue, I want to just give one example. This is myocarditis, where tissue characterization is very important. And you may have heard of the Lake Louise criteria. So these criteria are used to determine myocardial inflammation. There are 2 criteria. One is focused on edema, which is a marker of acute inflammation, and one is focused on injury, which is basically quote-unquote dead cells, which is reflected by certain techniques that can be used, T1 mapping, T2 mapping. I will not go into too much detail here. And then, as you can see, pericardial involvement and dysfunction are only supporting criteria. Actually, function can be totally normal, and I'll show you an example of that. This was especially important in COVID-19, and this can be performed, such a scan, also without contrast agents. And so I'll just go through that quickly. Edema is a hallmark of inflammation, and there is no other technology. Even for pathologists, it's difficult to visualize edema. And this is something I think that will lead to more new understandings of disease. For example, HFpEF is a disease that I am pretty sure is characterized by intermittent edema. And this tissue characterization is important. Here's the case of a 23-year-old patient who presented with acute infarct. That's how it looked like: ST elevation, chest pain, troponin. Then the echo was performed. The echo said normal. And indeed, the CMR that we performed thereafter confirmed that. It's a normal ejection fraction. There is not even, I could probably convince you or talk you into saying, okay, maybe there's a very, very mild wall motion abnormality here. But generally, anybody would say this is logically normal. So you would expect this, if that's myocarditis, it's probably not severe, right? But look at this, the extent of necrosis in this patient. All these bright spots are contrast-enhanced areas associated with irreversible injury, so necrosis. And as you can see here, there's extensive necrosis despite a completely normal appearing LV function. That happens because young people can compensate for that. So tissue characterization, clinically very important. And more recently, we can do that. And this has been also now in the Lake Louise criteria. You can do this even without a contrast agent. You can verify the myocarditis. This has been validated against biopsy, although, to be honest, I think it's more validation of biopsy against CMR because biopsy has a problem with sensitivity. And that's why we have to be careful with these validation studies. We always think biopsy, because they quote unquote see it, must be the best, but I can tell you with my own experience it isn't. So also important for the follow-up, the tissue characterization. So myocarditis, it's much more frequent than we thought. MR has shown us that it happens much more often. I bet, looking around here, 10, 15 people of you, especially the younger ones, probably had myocarditis and were not aware. But luckily, it's a benign disease in general. So not all of them get complicated and lead to heart failure, arrhythmia, etc. So, but this is where we can learn. And in general, because there's a frequent question, okay, after myocarditis, when can I go back to sports or whatever? So it's good for a while to not do sports, but the while means typically 3-4 weeks. If patients are asymptomatic, I think that's fine. But if not, then repeat the MR, and only if the MR shows that the inflammatory criteria are absent, then it's safe to go back. And while for, I want to almost say decades, it was a fight to establish that, it now has made it into the guidelines, the American guidelines and also the European guidelines, where cardiac MR is now next to biopsy a class 1 indication to verify but also determine the diagnosis of acute myocarditis. And I think there is no other technology I would use in uncomplicated patients. If you have heart failure, if you have checkpoint inhibitor-induced myocarditis, in some cases, biopsy may still be helpful. In giant cell myocarditis, for example, or suspected virus persistence, but that's less than 5% of the cases. Tissue characterization can also be enhanced then by using artificial intelligence. And this is a paper that was a collaboration between Montreal and Heidelberg, where we could show that MR images, when analyzed with artificial intelligence, can not only classify that a patient has amyloidosis, but it can also differentiate between ATTR and AL amyloidosis, and does so with a pretty high accuracy. So when we look at the area under the curve, and this basically automated analysis could identify every single patient with hypertrophy, but that, of course, it's not very difficult. But then even hypertrophic cardiomyopathy versus amyloidosis had an area under the curve of 0.99. So it's basically also always correct in differentiating the two. And then there was still a diagnostic accuracy of more than 90% to differentiate between ATTR and AL amyloidosis. And then even when we removed the contrast-enhanced images, and then removed, so basically we just looked for a needle-free scan. Still, it was the accuracy was 100% for detecting hypertrophy, was 95% to differentiate between HCM and amyloid, and was 86% to differentiate between ATTR and AL. So I don't think that in a center with access to CMR, a nuclear scan should be done for this purpose. And this is also software that will soon be available. Now let me shift gears to something very important, perfusion. So this is in a patient with a mild wall motion abnormality. And you see in the middle, you see the two scans performed with a dynamic assessment of the contrast inflow. And on the left one, the baseline, you see that there's a fairly homogeneous distribution of the contrast agent in the myocardium here in this short axis view. Whereas on the right side, you see that during adenosine infusion, some areas have a delay, which is consistent with the perfusion deficit. And then in the same session, if you do a so-called late enhancement scan of scar, you see that the scar is much smaller than the perfusion deficit. So in a patient with significant symptoms, despite optimal therapy and lifestyle measures, this scan indicates that there is a perfusion deficit in viable myocardium, therefore maybe a good indication for an intervention. This perfusion has been assessed. The perfusion MR has been known since my first study was in 1995. So this has been around since 30 years. But there has been a lot of backlash, especially from nuclear cardiology. But some studies have now convinced the community. And among them was this study, the MR Inform, I think very important because they didn't look at accuracy. Accuracy, if you think about it, doesn't mean that much if you cannot demonstrate that eventually using this technology in patients improves their outcome. If you just have nice images that confirm what you have known anyways, then there is no point. And this was done here. So it was compared, the perfusion scan was compared with fractional flow reserve in the cath lab, which was considered at that time the gold standard for looking at the severity of coronary artery stenosis. And they could show in this paper that using a non-invasive perfusion scan was just as good as the FFR in the cath lab to make a decision, and just as good means had the same impact on outcome. And then the good news on that was that in the CMR arms, there were less interventions, so less surgeries, less percutaneous interventions. So that was just one of the earlier, so more recent studies have actually extended that. So this is a comparison with SPECT, and if anybody needed some more information, that SPECT is not nearly as good as MR, this would have been one of the papers. So the accuracy was pretty much better in any of the criteria, especially positive predictive value and specificity. But then a paper that I think it's now published last week or so, which took us about 2 years to finally get it out. The ischemia trial, the largest trial on myocardial ischemia, $99 million, performed by the NIH, worldwide, so global centers. And there was a subgroup of patients who had a cardiac MR. And the question of this analysis was, how well does an abnormal perfusion scan predict outcomes? So if you have an abnormal scan, what does that mean? Will you get an infarct or whatever? And what did the data show? That it predicted outcomes. The primary endpoint, cardiovascular death / spontaneous MI, MI and cardiovascular death. But if we dig a little bit deeper and compare it with other modalities, something really striking is visible here. So the red bars means severe ischemia in the perfusion scan. The blue bar means moderate ischemia. The green bars, which you don't see here, means mild ischemia, and gray means normal. So in patients who received an MR scan, if they had severe ischemia, which are the red bars, you can see, let's just go for the left, which is the primary endpoint, 20% of them had an event. When they had moderate ischemia, 14% had an event. When they had a normal or mild ischemia, no event whatsoever. Which means if you have a normal MR scan, a perfusion scan, this is like a warranty for the next, and we think it's 5 years. That's, from my point of view, much better than doing a CT with plaques. But let's have a look how the other modalities perform, where they also could show that severe ischemia was worse than others. And look at that. This is pretty much random. So neither stress ECG, nor stress echo, nor SPECT could predict events in this analysis. In fact, in SPECT, the worst people were the people who had a normal scan. They had more events than the others. So here also a couple of Meyer curves, but they basically say the same thing, that MR predicts outcomes, and these are several sub-analyses, predicts outcomes better than any other imaging modality. Now, perfusion can, in the meantime, also be done quantitatively, and there is software out there that allows to do what PET used to do, so milliliters per gram tissue per minute. So perfusion imaging, if a center has access to an MR, is definitely the best way to look for significant myocardial ischemia, although I'm hesitating to use that word, because this is not ischemia imaging. This is perfusion imaging. It's a surrogate marker. Ischemia means there's a mismatch between oxygen demand and supply, and none of these scans does that. SPECT doesn't do that, echo doesn't do that, CMR doesn't do that. So just want to keep that in mind. We talk about inducible ischemia, but in fact it's a perfusion deficit. Just keep that for a minute because I'll come back to that. Another important, next to perfusion deficit, another important clinical entity is MINOCA. And MINOCA, so myocardial infarction, I hope it will be renamed soon in myocardial injury with normal coronary arteries, is something very important. It's up to 15% of our patients have infarcts defined by high troponin, clinical presentation, and even wall motion abnormalities, but eventually do not have a classical occlusion of a coronary artery. And so far it has been difficult, but we have learned mainly through MR that that MINOCA actually is an infarct only in about, or an otherwise undetected infarct in 22%, and the others are MINOCA mimickers. And these are myocarditis Takotsubo, and or they are completely normal. And MR is the only method that can tell you what it is, because it can tell you, is there a scar? Where is it? Is it more subendocardial, which would be an ischemic injury, or is it somewhere in the tissue, or subepicardial and it's more inflammatory, or a cardiomyopathy? So this is where tissue characterization again plays a huge role. And then I mentioned before hemorrhagic infarction. Everybody knows that if you have a stroke, you have to get into the hospital as soon as possible. It's the same for coronary artery disease. But then the stroke people typically say 2-3 hours, and then that's it. I will not reperfuse, because then in the brain it turns into hemorrhage, and then we have a disaster. In cardiology, we didn't think like that, but maybe we should. Because we have learned that hemorrhagic formation of infarction is a frequent complication of reperfusion, especially of late reperfusion. And there's a whole battery of new studies on that, and I will just mention it here and refer you to these papers. But the bottom line is hemorrhagic transformation of infarcts is a frequent complication of late reperfusion, basically because after a few hours, where you could still save myocardium, the endothelium of the coronary arteries gets leaky. The endothelium is more resistant to ischemia than cardiomyocytes. And so if you reperfuse early, your endothelium is still intact, and you reperfuse, so that basically the pipes are still pipes. But if you have leaky vessels because it's too late and it happens after 4 or 5 hours, then you will have an extravasation if you reperfuse of blood, of erythrocytes. And this is a disaster because of several reasons. First of all, the erythrocytes or blood, these are a very, very strong trigger for inflammation. With inflammation comes edema. With edema comes capillary compression. So in fact, you expand the infarction. And the other one, the even worse maybe, is that the extravascular hemorrhage leads to iron deposition. So you have iron. The iron is electrically unstable. And as studies from the Cedars-Sinai and from the University of Indiana have shown, this deposited iron comes with electrical instability. It's probably responsible for a lot of sudden deaths down the road. So think about it. A proper tissue characterization would help a lot. And I've been in the cath lab also myself for 2 years. I know how satisfying it is to open a coronary artery and then to see, hey, flow, look at this artery, it looks beautiful. But in fact, you initiated a disaster. So we have to learn much more about that, and MR is what will help us to understand that better. So I have to speed up a little bit. Imaging lung water, I just want to throw it out there. Lungs are typically the domain of CT, but this and some other studies have shown, and we also are starting a study ourselves, when you do a cardiac MR, you basically get information on pulmonary edema almost for free. So, okay, now let me shift gears. What I've talked about so far is classical cardiology. You have a patient with symptoms, and then you do a scan, and then you perform a diagnosis. Now, if we look into the future, medicine has to change. We cannot afford to continue waiting for everybody to get their symptoms and infarcts and then start treating. We have to be much better. Now, we have things like, okay, we should all run more and eat less. Yeah, that's fine, but who knows, is it really good for me? So then there you have on one extreme, you have the hyper-controllers who are on their Garmin all the time and say, oh, I have just 2,000 steps more to go. I'm totally tired, but I'll walk 5 times around the block. And then you have, on the other hand, people who don't really care what they're doing, that they let things happen as they are. But what we need is a kind of an individual management of their health. And it's not just to live longer. Living long can be a disaster if you're suffering all the time. So, but here's where the term health span comes in. So living longer, yes, but living longer better, that's actually what we should aim for, also in medicine. And I know we're all not, as clinical cardiologists or radiologists, we're not definitely thinking all the time about that, but we have to think a little bit out of the box. So let me focus a little bit on atherosclerosis. About 40% of people of the general population, have atherosclerosis. That's quite a lot. That's a disaster. In indigenous populations, before they got into the blessings of Western lifestyle, this is less than 5%. So we have a big problem. And it's not just having some plaques, but having plaques actually has consequences. So it runs the risk of clinical events, which then will impair the quality of life and also longevity. Now, the classical way to look at it is, yeah, there's more and more stenosis coming in, and at some point there will be a catastrophic event, but that's not what's really happening. Most of the infarcts are actually caused by coronary artery stenosis that are less than 60%. So sometimes I tell my patients, yeah, you have a 90% stenosis. That may be a good thing because your heart has already triggers to build extra vasculature around it. So the prognosis of an event of a coronary artery occlusion in a 70-year-old who had already 90% stenosis for 10 years is better than in a 50-year-old with approximate LAD stenosis, the so-called widowmaker stenosis, because there are no collateral vessels. But that's another topic. But in order to be early, in order to manage health, we have to also be early here. And this leads me to endothelial function. Endothelial dysfunction is the first abnormality that occurs. And it doesn't start at 50, 60, it starts at 30. It's 30 people with age of 35, if their lifestyle is not good, their endothelial function will not be good. And so there are lots of clinical studies that have shown that. Now, how do we look at endothelial function? So is it that we look at the coronary arteries? Well, no. And I sometimes compare it with trees. In the fall, it gets difficult for trees to survive. So some of them go into, basically, they go into hibernation. They throw off their, and if we compare it to the heart and say the leaves are the cardiomyocytes, it's unfortunately, we cannot just throw away our cardiomyocytes and have them back in spring. So we want to avoid that leaves get yellow or red. So we could look at the coronary arteries because at the big branches, but they only tell us one part of the story. In fact, we would like to know what's happening in the periphery. And endothelial dysfunction happens in the periphery. In fact, most of the capacity and the resistance, what is happening in the small arterioles and the capillaries. And there are two types of endothelial dysfunction, or microvascular dysfunction, if you like that term more. One is the more structural one. So you have a plaque, you have intima thickness, you have, for example, by high blood pressure, you have a low capillary density because of chronic diabetes or hypercholesterolemia, or because of edema. And then there's a purely functional aspect. So people may have an impaired vasodilation when it's needed, or an abnormal trend or tendency to vasoconstrict. And this is important. Why? Because the oxygen extraction in the myocardium is already at rest 70% or more. So there's no way we can, like in the muscle, that we can just extract more oxygen. No, the increased oxygen demand with physical exercise or with mental stress has to be met by an increase of blood flow. So increase of blood flow works through endothelial function. So imaging is chronically really bad at that. So we do not have good techniques. We have quantitative perfusion, we could do that. But we have shown that, or others have also shown that there can be a mismatch between perfusion and oxygenation. This is one of the studies from Oxford, and they concluded that 40% of myocardial segments with a blood flow that was below the cutoff still had no deoxygenation, so they were still fine. And on the other hand, 12% of segments that were considered normal, have a normal blood flow, had low oxygen levels. Or 80%, 88% with normal had also normal. So that makes, so here we have to be better. And this is where the oxygenation sensitive CMR comes in. And I will try to walk you briefly through that. This is a technique that is based on the phenomenon that deoxygenated hemoglobin turns into a contrast agent. So if you deoxygenate the myocardium and you deoxygenate hemoglobin, the signal intensity drops. This has been shown in the brain, and it's already used since almost 30 years as functional MR, but this can also be done in the heart. And this is the theoretical framework also done quite a while ago. We have done some initial proof of concept studies many years ago, and then in the work by Matthias Friedrich in Calgary, we could show that the change of signal intensity actually reflects blood flow. This is compared with coronary sinus blood flow and also with coronary sinus oxygen saturation. Has been confirmed by other groups. This is from Oxford. They compared it against PET, and then another study from Germany against FFR. So this technology has been proven over and over that we can track changes of oxygenation in the myocardium. And this is a much better surrogate marker for ischemia than just looking at blood flow. Now, but then there comes something else. We also wanted to get rid of adenosine. And adenosine is a nice agent if you need a pharmacological quote-unquote stress, a vasodilator. But adenosine has a problem. Adenosine works through adenosine receptors. They bypass the endothelium. So you cannot actually look at endothelial function with adenosine. So we say microvascular function, but in fact it's not really, it's missing the point. And then in an early experiment we found the following. And actually, to make it short, it has been known since more than 60 years that our breathing affects our myocardial blood flow and the blood flow in the brain. When you sit here and you just hold your breath now, if you would hold your breath, I don't want to force you to do that, but if you hold it, within 10-15 seconds, the blood flow to your brain and your heart will increase. And if you hyperventilate, the opposite happens. Your blood flow drops. In fact, so much that in the prefrontal cortex it may drop the oxygenation by 50%. This is known as the effect of carbon dioxide. So what I observed at that time, that in patients when they held their breath, nothing happened between the beginning and end to their oxygenation. But in healthy people, there was an increase. And initially, I didn't understand that because I thought, how can you have an increase of oxygen if you don't breathe? Where does the oxygen come from? But it's just kind of a luxury perfusion of the myocardium. And this is a wonderful experiment that was done that confirmed that. So carbon dioxide, if you breathe it out, if you get rid of it, hypocapnia leads to vasoconstriction in the brain and the heart, only there. And this leads to a reduction of blood flow and oxygenation. And then if you hold your breath, after hyperventilation, it goes from vasoconstriction to vasodilation. Again, within 15 to 30 seconds, you increase your blood flow. And we have done animal experiments, the coronary blood flow increased by 300 to 500%. So this has been also shown in the brain, not by us, but by others. And this is the protocol we're using for that. Now we replace adenosine with this breathing maneuver. So in fact, what we're doing, we ask people, after a baseline scan, we ask people to hyperventilate, which is just taking 30 really deep breaths, 1 second in, 1 second out. And then we ask them to hold their breath, and then we start imaging and watch what happens when they go into vasodilation. And this is what happens. This is a clinical study from Switzerland showing that if you map that, you can separate coronary artery territories that are subject to severe coronary artery stenosis, so this is more severe disease. And here, for those people who are, like me, interested in watching dynamic changes, so this is how it looks like when you normalize the oxygenation to the blood pool and watch what happens across the cardiac cycle. On the left side, you see an occlusion of the LAD, and you see that during certain phases, there's a relative deoxygenation in the left anterior descending territory. Here's an example of the RCA. You see it's the region. And this case is interesting because they had a stenosis in both the LAD and circumflex. And you see that in between, and you see that better here, in between there's an area that seemed to be normal. So why would there be a normal between two abnormals? And then if you do the perfusion scan, you see, okay, perfusion is really abnormal just in that area, so it's a false negative, right? So that's what you would think. But no, the perfusion is false negative and false positive. Because if you look at the late enhancer, you see there's a small scar exactly in that region. And now if you go back to the oxygenation, it's pretty clear. The scar doesn't need a lot of oxygenation, so why would there be deoxygenation? That's why it's normal. But the perfusion has missed the area around it that had deoxygenation, but was not visible in the perfusion scan. So this technology has been now used, the breathing maneuver has been used in several studies. So these are just a few. This is not even using oxygenation sensitive MR. This is looking at strain. And we compared in Heidelberg, we compared adenosine with the breathing maneuver, and it was at least as good as adenosine. And the scan only took 60 seconds. And again, no contrast agent involved here. Then we applied it to patients with acute coronary syndrome, and in fact it was more sensitive than even troponin in identifying early patients with acute coronary syndrome. We looked at it in HFpEF, so HFpEF with microvascular dysfunction. Also, this was a very frequent phenomenon. We looked at women with angina and normal coronary arteries, and there we found something really interesting. The overall response was pretty normal, but it was very heterogeneous, which means probably that women, and it's clear that women respond to stress differently than men. Women literally take it to their heart. And we guys don't do that. I think my gut feeling is that we take it to the brain. That's why we get stupid when we're stressed. But women literally take it to the heart. They get edema, and Takotsubo is the end of the spectrum, but I'm hypothesizing that in between we have lots of mini Takotsubos, especially in postmenopausal women, that then can lead to symptoms like in ANOCA, but also chronically to heart failure, which is then HFpEF. And it's not homogeneous, but certain areas, and in women we also know that the distribution of receptors, beta receptors, is also heterogeneous, so this may be explained by that. We have shown that this is the same happens in the brain. In the brain, this was even in heart failure correlated with cognitive function. And now comes the nice part. We can analyze that even automatically, and we can track the oxygenation across the cardiac cycle, which we call the oxycardiogram. It's like an ECG just of the oxygenation. And this gets now very interesting, because we have observed that, for example, in patients with endothelial dysfunction, proven by acetylcholine injection to intercoronary arteries, that the response to these breathing maneuvers, to the hyperventilation and to the vasodilation, shows specific patterns. And it's when you look at Eindhoven, when in 1899 he had the first ECGs, they didn't have a clue what these curves would mean. And I think we're at a similar stage now. We're just starting to understand that these curves reflect physiology that we can now start to better understand. And with that alone, we had an accuracy of more than 80% to identify, actually the overall accuracy was 92% here, to detect endothelial dysfunction. Now this is also work by Daniela. She presented that actually last week in Rio at the SCMR meeting, where she looked at 4 different cohorts. So on the left side, you see the oxycardiogram, the average oxycardiogram of healthy people, people with risk factors, people with microvascular disease, and coronary artery disease. And you see they behave differently. Now we have, for example, here you have this deep dip in patients with coronary artery stenosis that is not visible in the others. So if you extract biomarkers that reflect this curve behavior, then you get to accuracy levels of 92, 94% to not only differentiate between normal and abnormal coronary function, but even within coronary abnormal function, whether it's microvascular or macrovascular. So this is not published yet, so we will have to, we have one paper is in revision, but this will later during this year and we have now 19 collaborating centers worldwide, and I hope La Cardio will be number 20 that apply that now in research, and we have also the first centers that apply that clinically. And then to put a cherry on top of the cake, we have also done some preliminary work extracting information from these images, from the very same cine images that allow you to extract strain and the oxygenation, looking at the same images to extract tissue characteristics. So for example, amyloid and cardiomyopathies, ischemic or non-ischemic, and edema. So think about it and let that slowly sink in. If you have a scan, after a preparation of 10 seconds, hyperventilation, and then scanning for 30, 40 seconds, then you extract information on vascular function, can differentiate with macrovascular. You extract strain, can correlate that with dysfunction. And then a scar or edema, and also with a high diagnostic accuracy. So that's why I hope at some point we will be able to do the following. For certain indications, certainly for congenital, you would need more. For valvular disease, you need flow on top of that. But for frequent questions of viability, is there inducible ischemia? And now we can really say ischemia. We could have a short protocol like this, and then have maps. And I'm specifically saying maps because I think in the future we should not have black and white images that only a few people understand and explain to the referring physician, or we should report what we see as a map of physiology or pathophysiology. And this would be a map of muscular function. This is basically a strain map, a map of tissue pathology, edema, fibrosis, and a map of vascular function. So I hope that I can live to the time where we get to a point where imaging becomes something that is not only easy and safe and cost efficient, but also is easy to understand by a referring physician, and then hopefully improves outcomes. So let me summarize. Cardiovascular MR is by far the most powerful imaging modality, giving it safety, versatility, and unique capabilities. It is, however, limited by complexity, long scan times, cost, and expertise needed. But novel protocols, and I showed you one of those, combined with artificial intelligence, probably helps us to remove most of these limitations and making MR not only the most versatile and best, or theoretically best, but also the most efficient modality. And then with a wide spectrum of clinical use cases, complementary to echo and CT. Thank you very much.
Like 200 people, huh?
Oh, you have to come here.
Yo creo que tenemos espacio para dos preguntas. We have time for 2 questions. Anyone? ¿Alguien quiere preguntar? Sí.
I have just one simple question. I am very curious how this idea came from. You wake up one morning and say, I think this rate can be a tool for diagnosis cardiology. Where this came from? That's my question.
Sorry, I didn't fully understand. Whether I woke up one day and thought this could happen?
Yeah.
No, but you're not far away from the truth. In fact, this idea of the oxygenation sensitive MR in the heart using breathing maneuver, in fact, happened on a Sunday morning at 5:30 when I woke up. And I thought about what I could do next and where we have a clinical need. So it was born on such a morning. And when I did these experiments and saw that in patients nothing happened and in healthy people it went up, I was confused and I didn't know what am I doing wrong here. And this was in hindsight the best moment of my career, that I was so confused, because it was something that told me there is something to learn here. And then when I realized, wow, this is the coronary flow reserve that is recruited here by this breath hold, I was so excited I didn't even tell you, Silke, for a few days, because I enjoyed being pregnant with this idea. And this is when it started, but I knew this would be at least 10, 20 years. It's now almost 30 years. And I'm still working on, but I think we have long ago passed the point of no return. But you're right, it's sometimes we just have to be open. We have to have the antennas open for new ideas. We don't think about something and then come to a certain conclusion. That's also nice. But the best things are coming by themselves.
Thank you, Doctor, for your talk. Wonderful. But here in Colombia, we are in a resource-limited health system. There is an imbalance between the rising new technologies and the expensive of these kind of technologies. So, we're in the context of coronary artery disease, where do you think is the best moment to do MRI compared with other images, like to have benefit in cost?
Okay, yeah. So thank you very much for the question. I am not a fan of throwing technology to people early, period. When I'm seeing my patients and they tell me about chest pain, I'm not sending them to an MR right away. First of all, I do a careful history taking. And if I still believe it's coronary artery disease, then I would recommend lifestyle modification as much as possible. If that doesn't help, I have to give them medication. Only if that doesn't help, they still have symptoms, despite optimal medical therapy and all I could do for lifestyle, then I may think of a scan. And then I send them first to, I would send them to a cardiac MR. And actually there are studies, because you said resource, this is the best reason to do MR, to think about it. It has been shown for the US, for several European countries, and also for middle-income countries, that the early use of cardiac MR drops the cost for diagnostic work of coronary artery disease by up to 50%. Which means within few years, and even using the old protocols, including contrast agents, etc., within a few years, you can amortize a complete MR scanner. That's why insurance companies, I have a good friend of mine, he is in Berlin, he runs a private practice, and he has deals with insurance companies. He does stress MRs, 8,000 a year in that practice. And he has contracts because the insurance companies say it saves us money. Less people go to cath labs for invasive procedures. People are better treated. Follow-up is more targeted. So yes, I agree. We have to be careful. And this is one of the reasons I think we have to change medicine. We cannot spend 70% of our GDP, like in the US, for healthcare. It's just not, and it gets worse and worse over time. So we have to be resource conscious. And I think the clever use of an MR can be a very important component of that. So I agree, it's painful to purchase these magnets, but eventually the math adds up to be less problematic and in fact more cost efficient than doing it the old way. Doing a stress ECG with a diagnostic accuracy of 67%, doing a SPECT with 67%, which is, by the way, more expensive than an MR, and comes with all these risks with the radioactive traces. So it's a very good question, and it has to be set up in an intelligent way with clear protocols and clear indications, and not everybody right away, but first max out all the other options, but then use it wisely.
Any other question? I have a final question and commentary. So of course as soon as I saw OSCMR, I fell in love with the idea. I mean, it's groundbreaking only by the idea of the response to oxygenation and the measurement of oxygenation in the myocardium. When do you think we're going to have it ready for certain pathologies? Let's say ready for MINOCA. I think in MINOCA, for example, that it become a pathway. Yeah. When do you think that we're going to have it?
So the short answer is it is available right now for research. The company Area 19, so again, I'm wearing also this hat, just be aware. The company owns the patents for that. The company is run by 5 people who are all scientists by heart, so it's not the typical company, it's a startup. Attempts to get FDA certification later this year. And then as soon as it's done, it will be available. And probably it over mid and long term will be available for all platforms, Philips, Siemens, GE, and what have you, and even as a standalone, but it's not decided yet. Because as a startup, we definitely don't want to have a global company with support people everywhere. No, we just want to make this available. So short answer, research right now. Clinically, probably early next year.
So with that, we conclude. Con eso concluimos. Muchas gracias a todos por asistir. Thank you, Dr. Friedrich.
Thank you. Thank you.